Imagine moving into a brand new house, right? Everything looks perfectly normal from the outside.
Yeah, standard neighborhood, perfect paint job.
Exactly. But you go to open a door in the main hallway, and you're expecting to walk into the living room, but it just, it hits a solid brick wall.
Oh, wow.
Or maybe you discover this entire hidden room that isn't anywhere on the official floor plan. And while for millions of women globally who experience really severe, deep pain during intercourse, this kind of unexpected architectural anomaly isn't just a metaphor.
Right, it's their literal physical anatomy.
It really is. And that's why we're dedicating today's deep dive to you, the listener, to unpack this heavily misunderstood reality. We are looking at how congenital cervical or uterine anomalies physically alter the experience of intercourse and actually lead to deep dyspareunia.
It really fundamentally changes the whole conversation. Because when we talk about pain during sex, the narrative so often defaults to psychological factors or maybe temporary infections.
Yeah, like it's all in your head, or it's just a UTI.
Exactly. But looking at the structural blueprint of the body shifts that entirely. I mean, it moves the discussion from this subjective emotional experience directly into objective, undeniable anatomy.
Which is so validating. And to do this, we've pulled together some truly fascinating sources. We're drawing on clinical guidelines from the Royal College of Obstetricians and Gynecologists, clinical FAQs from the Women's Health Clinic, some peer-reviewed medical literature on Mullerian anomalies, and this really eye-opening medical case report from the Frontiers in Reproductive Health Journal.
And just to ground this in reality for you listening, the World Health Organization estimates that anywhere from 8% to 21.1% of women globally experience pain during sex.
That is a staggering portion of the population.
It really is. And while dyspareunia is incredibly complex, it's often a mix of hormonal drops or pelvic floor dysfunction or past trauma. Zooming in on the structural congenital causes reveals this entirely different mechanical landscape.
So, to understand how that landscape gets altered, I feel like we need to understand how it's built in the first place, right?
Definitely. We have to look at the developmental blueprint.
Because, how does a uterus actually form inside a developing embryo? I always just assumed it grew as a single, hollow organ from day one.
That is the common assumption, yeah.
Yeah.
But the reality is much more intricate. When a female embryo is developing in the womb, the reproductive tract actually begins as two entirely separate, parallel tube-like structures.
Wait, really? Two distinct tubes?
Yeah, two tubes. They're called the Mullerian ducts.
Okay, so how do we get from two parallel tubes to a single uterus and cervical canal?
It requires this highly coordinated, basically a two-step biological process.
Yeah.
So as fetal development progresses, those two Mullerian ducts migrate toward the center of the body.
Okay.
The top portions remain separate and eventually become the fallopian tubes, but the lower portions are programmed to push together and essentially fuse in the midline.
And that fusion creates the outer shell.
Right. It creates the outer shell of a single uterus, a single cervix, and the upper two-thirds of the vaginal canal.
But simply pushing two tubes together doesn't magically create an open, hollow cavity. If you press two straws together, you still have the inner walls touching in the middle.
Exactly. And that brings us to the crucial second step, which is resorption.
Resorption.
Yeah. Once those ducts fuse, there is a thick dividing wall running straight down the middle of the newly formed uterus, which we call a septum.
Okay, I'm picturing that.
So for standard development to finish, that septum has to actively break down and dissolve or resorb, leaving behind one continuous hollow uterine cavity.
I like to visualize this like hiring a contractor to convert a duplex into a single-family home.
Well, that's a good analogy.
Right. You've got these two separate living spaces, which are Mullerian ducts. The contractor pushes the two units together, but if they completely forget to knock down that middle structural wall between the two apartments, you end up with a septate uterus.
Yes, exactly.
The outside of the house looks like one normal building, but inside the space is physically divided.
And the septate uterus is actually the most common of these structural anomalies. It represents a perfect fusion, but a complete failure of that secondary resorption step.
Wow.
Yeah, so our architecture is standard, but the internal cavity is compromised by that lingering wall.
Okay, so taking that contractor metaphor a step further, what if they only show up to build half the house to begin with?
Then you are looking at a unicornuate uterus.
Unicornuate?
Yeah. This occurs when one of those initial Mullerian ducts completely fails to develop or maybe stops growing very early on.
So it's just half a uterus?
Basically. The resulting uterus is roughly half the normal size, often described as sort of banana-shaped, and frequently there is the disconnected rudimentary horn left over.
A rudimentary horn?
Yeah, it's like a tiny, underdeveloped piece of uterine tissue just floating on the other side.
We definitely need to put a pin in that rudimentary horn because our medical case study later shows exactly how much havoc that tiny piece of leftover tissue can
Oh,
cause.
absolutely. It's a huge factor.
But let's say both ducts are present, but they just refuse to fully merge, like they don't fuse properly.
That partial failure to fuse creates a bicornuate uterus. So instead of a smooth, rounded top, the uterus is heart-shaped, or basically two-horned.
Okay, with a deep indentation dipping down into the cavity.
Right. And in the most extreme cases, where the ducts completely fail to fuse at any point, you get uterus didelphys.
Which is a completely duplicated system, right? Two separate uteri.
Two uterine and two cervices. It happens in roughly 1 in 3,000 cases.
That is wild.
And in fact, in about 70% of didelphys cases, the vagina itself is also divided by a longitudinal septum, meaning there are literally two distinct vaginal canals.
What's so crazy to me about the sources is that someone could be walking around with a fully duplicated reproductive system or a heart-shaped uterus and have absolutely no idea.
Totally. The sources emphasize that many people with these anomalies are entirely asymptomatic for most of their lives.
I guess if menstrual blood has a clear exit pathway, and if the person isn't trying to conceive, since these structural variances can, increase the risk of miscarriage or preterm birth, the anomaly might just remain hidden.
Right. But whether you feel it day to day or not, these structural variations significantly alter your regional anatomy.
Meaning, it isn't just a quirky variance in the shape of the room. If the contractor messes up the walls, it also means the furniture, like your ovaries or your bladder or bowel, ends up in unexpected places.
Exactly. The architectural footprint of the entire pelvic floor changes,
So during intercourse, you aren't just dealing with a different internal shape, you are actively changing the physics of how the body moves and accommodates pressure.
which transitions us perfectly into the mechanics of the pain itself. Because when you change that footprint, the way those internal organs interact with external forces during sex changes dramatically.
Yeah, so to understand those mechanics, we have to clearly separate the types of pain being experienced. I noticed the literature draws a very hard line between superficial dyspareunia and deep dyspareunia.
It is a vital distinction for anyone trying to navigate a diagnosis. Superficial dyspareunia is pain felt immediately at the vaginal entrance or the lower vaginal canal.
So like right at the opening.
Right. This is frequently linked to conditions like vestibulodynia, where the nerve endings at the opening are inflamed and hypersensitive to any touch, or vaginismus, which involves involuntary guarded muscle spasms of the pelvic floor, basically blocking entry.
And those are incredibly painful conditions, but they occur at the gateway. Today, we are focused on the deep interior.
Right, deep dyspareunia. This is pain perceived high up inside the upper vaginal vault or deep within the pelvic cavity itself, specifically during deep penetration.
So wait, I have a question about this. If the anatomy of the uterus and cervix is structurally altered by these congenital anomalies, does that mean the cellular makeup of the tissues is altered too?
What do you mean?
Like, are we just looking at severe internal dryness causing extreme friction? Is the lubrication system essentially broken?
I see. It's an intuitive jump to make, but Dr. Farzana addresses this exact misconception brilliantly in the Women's Health Clinic FAQ.
Oh, she does.
Yeah. She stresses that when we deal with unusual anatomy, we have to separate plausible mechanical causes from highly unlikely mucosal ones.
So a heart-shaped uterus doesn't mean the tissues are just dry?
Usually no. Dr. Kahn explains that anomalies like a septate or bicornuate uterus affect the internal womb cavity itself. They do not typically alter the secondary mucosal secretion patterns of the lower vaginal canal.
Okay, that makes sense.
True low-moisture tissue change is overwhelmingly driven by systemic hormone drops, like the loss of estrogen during menopause or postpartum.
Got it. So if a younger patient with a congenital anomaly is experiencing severe deep pain, blaming it on dryness is often a clinical misstep.
A huge misstep, yeah. The pain we are talking about here is strictly mechanical and structural.
It's not a moisture problem, it's a collision problem. Let's break down those physical mechanics, because the sources highlight a few specific ways this altered architectural footprint actively generates deep pain.
The primary mechanism is exactly what you just labeled it, collision and pressure.
Right.
Because a unicornuate or bicornuate uterus might be smaller, displaced off to one side, or Retroverted, meaning it tilts backward toward the spine instead of forward over the bladder, deep thrusting during sex can physically strike the cervix at an awkward, highly sensitive angle.
Or it might bump directly into an ovary, right?
Yes,
Yeah.
exactly. If the congenital anomaly has caused the ovaries to sit lower in the pelvis or drop into the cul-de-sac behind the uterus, deep penetration can literally compress that ovary.
And ovaries are highly innervated visceral organs. I mean,
Well,
hitting one sends a sudden, sharp, breathtaking pain signal straight to the brain.
it does. That is a completely normal neurological pain response to an abnormal blunt force pressure on a sensitive internal organ.
It sounds excruciating.
But there is a second, even more insidious mechanism at play with these anomalies, involving obstruction and mass effect.
Ah, this brings us back to that disconnected rudimentary horn we put a pin in earlier. Or something like a transverse vaginal septum, which is essentially a horizontal wall blocking the upper canal.
Right, these are obstructive anomalies. They basically trap the body's natural processes.
How so?
Well, if you have a non-communicating rudimentary horn, meaning that little extra piece of uterine tissue has a functional endometrial lining that responds to hormones, but it has no exit pathway connecting to the cervix, it bleeds every single month during menstruation.
Oh no. But that blood has nowhere to go.
Exactly. So you end up with a literal blood lock inside the pelvic cavity.
A blood lock. Wow.
The medical term is hematotrota. This trapped blood accumulates month after month, forming a painful, growing pelvic mass.
And that just makes the entire surrounding pelvic region highly inflamed, swollen, and exquisitely sensitive.
Yes. When you introduce the physical pressure of deep penetration into a pelvis that is already battling a swollen inflammatory mass, the pain is debilitating.
And if that blood can't go down and out, physics dictates it has to go backward,
Oh.
which triggers a massive secondary driver of deep sex pain, right? Endometriosis.
Spot on. Retrograde menstruation. The trapped blood is forced backward up through the fallopian tubes and spills out into the open pelvic cavity.
And then those stray endometrial cells implant on the outside of the uterus, on the ovaries, or along the bowel lining.
Right, and those cells continue to bleed every month, creating adhesions.
For those of you listening who aren't familiar with adhesions, imagine thick bands of internal scar tissue acting like biological superglue or dense spider webs, fusing organs together that are naturally supposed to slide freely past one another.
That loss of mobility is crucial. Normally, during intercourse, the pelvic organs shift, elevate, and glide out of the way to accommodate penetration.
But if your organs are anchored down and glued together by endometriosis caused by an obstructive anomaly, they can't move.
They're stuck. The physical thrusting pulls on those dense adhesions, resulting in this intense, deep tearing sensation.
So we have collision with displaced organs, we have trapped blood masses, and we have the superglue effect of adhesions. It is a profoundly physical, mechanical reality.
It really is.
But diagnosing that hidden mechanics, that is where this deep dive gets incredibly frustrating and honestly reveals some deep flaws in medical bureaucracy.
Oh, absolutely.
Let's look at the case report from the Frontiers in Reproductive Health Journal.
This case perfectly illustrates the diagnostic nightmare patients can face. We have an 18-year-old patient who presented at a specialized tertiary care center with severe cyclical pelvic pain.
And she rated it a 10 out of 10 on the pain scale.
Right. 10 out of 10.
10 out of 10 is paralyzing. It means you can't walk, you can't function. And what's wild is that she had already sought help at an outside institution.
Yeah, they performed a standard transabdominal ultrasound. You have a wand on the outside of the belly along with an MRI.
And the initial radiological report from those expensive high-tech scans completely misdiagnosed her. They concluded she likely had necrotic fibroids or a complex ovarian tumor.
Which is an utterly terrifying misdiagnosis to hand an 18-year-old.
Terrifying. But why did it happen?
Well, when we look at the clinical realities, we can trace exactly why the standard imaging failed her. First, her BMI was 31.6.
Okay, how does that affect it?
Transabdominal ultrasounds have to send sound waves through the layers of the abdominal wall. A higher BMI can severely compromise that acoustic window, absorbing the sound waves and rendering the images blurry or entirely inconclusive.
So the outside-in approach couldn't get a clear picture. And in a typical gynecological setting, the gold standard for getting a high-resolution, near-field image of the uterus and ovaries is the transvaginal ultrasound, or TVUS.
Right. But the doctors couldn't use that tool here.
Why not?
The patient had an intact hymen. A standard transvaginal ultrasound requires inserting a probe into the vaginal canal, making it contraindicated in her case.
So the external scan was blocked by tissue depth, the internal vaginal scan was impossible, and the MRI, which actually requires highly specialized radiological expertise to spot these rare Mullerian anomalies, was misinterpreted.
Exactly. She was trapped at a complete diagnostic impasse.
Until the doctors at this new tertiary center decided to pivot and utilize a different point of care solution, they opted for a transrectal ultrasound, or TRUS.
Yeah. With the patient's full informed consent and utilizing strict clinical safeguarding protocols like having a medical chaperone present, they used the standard endocavity probe rectally.
Because the rectal wall sits immediately behind the vaginal canal and the uterus.
Right. This approach completely bypasses the hymen. It provides a high-resolution close-up view of the pelvic organs that is virtually indistinguishable from a transvaginal scan.
And the clarity of that image changed everything. It wasn't a necrotic tumor at all.
Not at all. The transrectal scan allowed them to correctly diagnose a left hemiuterus, a unicornuate uterus, with a non-communicating rudimentary horn that was basically ballooning with trapped menstrual blood.
So they mapped her exact anatomical blueprint in real time.
They did. Armed with an accurate structural diagnosis, the surgical team was able to perform a targeted laparoscopic procedure, minimally invasive keyhole surgery, to remove just the abnormal rudimentary horn, completely preserving her healthy left uterus and ovaries.
And at her follow-ups, her 10 out of 10 pain was completely resolved.
Completely gone.
She went from debilitating agony and a terrifying tumor misdiagnosis to being completely pain-free simply because the medical team used an anatomically logical imaging tool.
It's incredible.
Which leads to a massive, glaring question. If the transrectal ultrasound is so incredibly effective when a vaginal ultrasound is an option, why isn't this the standard automatic fallback for any patient in this situation?
Well, that question cuts right to the heart of a fascinating and deeply frustrating conflict in international medical guidelines.
Tell me about it.
The researchers who authored this case report specifically call out the contradictory, frankly paternalistic guidance that clinicians are forced to navigate when trying to help these patients.
Let's dissect this guideline paradox. How contradictory are we talking?
Very. On one side of the medical establishment, you have the ES-REACH-G consensus, representing major European reproductive societies.
Okay.
Their official guidelines implicitly permit the use of TRLS for evaluating the uterus, but they explicitly ban the procedure for the demographic they label adolescents.
Wait, they just categorically ban it for an entire age bracket. Do they provide a physiological or medical reason for that?
They offer no explicit medical justification for the restriction. And the term adolescence is this broad biological umbrella that technically covers ages 10 all the way up to 24.
Wow. So under those guidelines, our 18-year-old patient in the case report who is a legally consenting adult would be denied this life-changing diagnostic tool simply because she falls under an arbitrary age classification.
Exactly. It's incredibly rigid.
It prioritizes a biological label over a patient's immediate suffering. What about the other side of the medical establishment?
On the other side, you have the British Medical Ultrasound Society, or BMUS. Their guidelines take a much more modern approach to patient autonomy.
Oh, that's good.
Yeah, they explicitly champion the concept of informed consent, firmly stating that anyone over the age of 16 has the full legal capacity to consent to intimate examinations.
So they trust the patient to make their own choices. That sounds like a much better framework.
You would hope so, right? But BMUS then abruptly contradicts that autonomy by categorically rejecting transrectal ultrasound as a valid modality for this type of gynecological imaging altogether.
Wait, what?
Yeah. Their official stance is that there is no evidence to indicate it is an acceptable alternative to transvaginal ultrasound.
But how can a medical society claim there was no evidence when we literally just read a peer-reviewed medical case report demonstrating that it solved a 10 out of 10 pain crisis when all other non-invasive methods failed?
It exposes a massive tension between population-level medical bureaucracy and individualized clinical care.
It really does.
These guidelines are undoubtedly drafted with the very valid ethical intention of protecting young or vulnerable populations from discomfort or distress.
Sure.
But the authors of our case report point out the inherent paradox. When you create rigid age-based bans or categorical rejections of specific modalities without looking at context, you strip a consenting young adult of an anatomically logical, minimally invasive diagnostic tool.
So the real takeaway here isn't just that a transrectal ultrasound works. It's that our medical guidelines are currently structured in a way that sometimes prioritizes generalized bureaucratic rules over solving a consenting adult's very real pain.
That's the tragic part.
The biology didn't fail this 18-year-old, the system did. Because the rules are fighting with each other, a patient with an intact hymen and an inconclusive external scan is essentially told, sorry, we aren't allowed to look any closer.
And if advanced imaging like an MRI is delayed, heavily waitlisted, or simply unavailable, which is incredibly common in low-resource medical settings, these patients are left floating in a diagnostic void.
Just living in agony.
Exactly. This is why the case report authors are advocating for a pragmatic algorithm where TRUS is actively offered as a second-line problem-solving tool for consenting older adolescents and young adults when standard imaging hits a wall.
It is about bridging the gap between conflicting guidance and real-world clinical necessity.
Absolutely.
It is a powerful reminder that healthcare isn't just about understanding the biology, it's about whether the system actually allows practitioners to look at the biology.
Very well said.
So, bringing all of this together for you, the listener, what are the ultimate insights from today's deep dive?
The most crucial takeaway is absolute validation. If you or someone you know experiences deep pain during intimacy, it is not just in your head, and it isn't merely a psychological hurdle of needing to relax.
Right. It can be the direct, undeniable mechanical result of a unique congenital structural blueprint.
Exactly. An internal landscape that you were born with that silently shifts your internal organs, alters your vaginal angles, creates agonizing physical obstructions like trapped menstrual blood.
Understanding that shifts the burden of guilt entirely.
And while our focus today was heavily on the structural and mechanical causes, the sources also consistently emphasize the biopsychosocial approach.
Oh, that's so important.
You cannot separate the physical reality of a congenital anomaly from the psychological toll it takes. Chronic physical pain, especially pain intimately tied to sexuality and relationships, inevitably impacts body image, mental health, and emotional well-being.
It becomes an exhausting loop, particularly when the medical system struggles to give you a clear structural diagnosis. But knowing these anatomical possibilities exist empowers you as a patient to ask highly specific questions, to push back against generic diagnoses like dryness, and to advocate for more precise, targeted imaging.
Empowered patients change the system. When you understand your own potential architectural blueprint, you can guide your clinicians toward the right diagnostic tools.
As we wrap up, I want to leave you with a final thought to mull over. We've spent this entire time discussing how easily these congenital anomalies hide from standard ultrasound waves, and how a slight change in an acoustic window can leave someone in agony for years, misdiagnosed with a tumor instead of a hidden uterus.
It's a sobering reality.
It is. So if our internal physical anatomy can vary as wildly and uniquely as our fingerprints, sometimes remaining completely invisible until it causes a structural collision, how might the rapidly approaching next generation of non-invasive, AI-driven medical imaging completely rewrite our fundamental understanding of what a normal human body actually looks like on the inside?
It's a profound question. Our current definition of normal is heavily biased by what our current tools can easily see. When the tools evolve to see more, the very definition of a standard human blueprint will have to expand.
And maybe we'll realize that the standard factory model of the human body was always a myth. Thank you for joining us on this deep dive. Keep asking questions and keep exploring the blueprints.